Okay, here we go. Okay, good evening, everybody, and welcome. I'm delighted to be here. My name is Noelle Hoven, and I'm a breast and body faculty here at the University of Minnesota and the Associate Program Director for the DR program. I like crunch cones from from Dairy Queen. I like making learning fun, spending time with my family, Disney, and any excuse to explore the world. So I'll be serving as your moderator tonight, so bear with me as I kind of run the show here. I'll do my best. So welcome. I hope this meeting finds you well and healthy, and I thank you all for taking time out of your day to come and chat with us tonight. I think 2020 is bringing new opportunities for resiliency, and just like you, programs are having to pivot and adjust in this new era of virtual meet and greets. So thank you. Explore Minnesota is a website that talks about, some things that we're known for. And so some fun facts, we're home to the headwaters of the Mississippi up by Itasca. We're known for lakes, so some of you knew that out there. You might think we're known for 10,000 lakes, but we're actually known for 11,800 plus and probably counting. We have events throughout the year to celebrate various cultures throughout the state. We're home to the Minnesota State Fair, which is near and dear to my heart. So you can indulge in things like cheese curds, for those of you who knew of those out there. Things like deep fried candy bars and food on sticks. That's a big thing in Minnesota. And despite the cold and the snow, there's a lot of things to do outside. Anything from biking to running to skiing, downhill, cross country, fishing, golfing. There's a lot of things to do outdoors. So with that, again, it's helpful to see who's out there. And I'd like to transition into introducing our panelists for tonight's event. So first, I'd like to have the residents that are out there say hello, kind of give a friendly wave. So we've got some residents out there. You'll notice for the viewers out there, their names are listed along with their year in residency training, in radiology training. And then we also have some of our faculty members from the program online too. Can you raise a hand and wave, faculty? Hi, yes, okay, good. And then I'd like to introduce a couple of the faculty specifically. So I was saying I'm going to give an air high five to a couple of you here in particular. So starting out with our departmental leader. Pre-COVID, he hosts an annual golfing event followed by a barbecue at his home. Despite a busy schedule, he prioritizes each week to teach our R1 residents radiology. Did I mention he manages to root for both the Ohio State and Minnesota for football? Please welcome our chair, Dr. Charles Dietz.
Hi, welcome everyone.
Okay, moving on over to the left of my monitor, when she's not working tirelessly for her residents or medical student mentees, you can find her in the pediatric reading room teaching and taking care of her patients or spending time with family. She's approachable, kind, smart, practical, and a trustworthy colleague. Please meet this outdoor explorer and deep sea diver, Dr. Tara Holm, our program director for DR.
Hi.
Okay, next, moving over, I'd like to introduce a leader in the IR suite, mom to 2 adorable fur babies, which we saw one earlier today, I don't know where he went, and world traveler. In addition to her exceptional research in the world of IR, she is author, which I found out recently, to 112 articles and contributed to over 400 cases on Radiopedia. In her spare time, she likes to learn new things like become conversational in Japanese, no big deal. Please welcome IR and IR Integrated Program Director, Dr. Donna D'Souza.
Hi, everyone.
Okay, we're gonna go across the river here. Okay, there he is. Matt, are you on the line?
I am.
Okay, excellent. Okay, the cat's out of the bag here. So this previous champion wrestler and ultimate Frisbee lover is not only dedicated physician to his patients and great at teaching residents, he was instrumental in leading COVID planning efforts with the team at Hennepin Healthcare and served as the interim hospitalist director right in the middle of everything. Leading the transitional year is program director, Dr. Matt Young.
Hi, everyone. Thanks. You must have good Googling skills, it seems.
No, she just knows E-Way.
Okay, this next panel faculty member is a previous resident colleague of mine. Most recently, he helped design a new resident rotation with an emphasis on outpatient procedural skills. We've grown up in the department together, and I'm super excited to share this new role and leadership with this next colleague of mine, Associate Program Director of the IR Integrated Program, Dr. Reza Talay. Reza, are you out there? There you are.
I am here. Hi, everyone.
Welcome. Okay, last but certainly not least, you know she's beloved by residents when they go out of their way to say hello during a resident supper club outing. She's a passionate superhero for women's rights and social justice and a trustee sidekick in the transitional program. Please welcome Dr. Samantha Pace.
Hi, everyone. Welcome.
Okay. So from here, I'd like to kind of hand it over to some of these leaders to go over some program highlights. And so starting us out is going to be Dr. Tara Holm.
Okay, so Dr. Holman has done a wonderful job introducing everybody. This is an overview of our campus. The Mississippi River runs right through it. The adult hospital is on the east bank, and the pediatric hospital is on the west bank. And of course, Hennepin County is even a little bit further across the river as well. Our campus has wonderful facilities, all kinds of activities, a great gym that everybody can work out in. Our city is home to multiple professional sports teams. We have all kinds of arts and entertainment going on, both on campus and around town. People have found some pretty creative ways to adjust to COVID, including putting the opera in the stadium. These are pictures that our residents submitted of things they enjoyed doing in 2019. Dr. Hoven's beloved State Fair makes it on there, and all kinds of family and resident activities. 2020, it looks a little bit different. The State Fair was now in a parade of cars. Family events obviously are a little bit more socially distanced, and everybody is spending a little bit more time outside. We are the land of greater than 10,000 lakes, as Dr. Hoven has pointed out, and people enjoy them in group, as they did in these pictures. We've got residents out sailing, residents canoeing, family events, Dr. Hoven canoeing with her family, and also people enjoy the great outdoors here in Minnesota on a more solitary basis as well. We don't really let winter slow us down here. All kinds of activities still go on when the lakes are frozen, those cold lakes that we pulled about. The cities themselves are second to Portland for number of bike commuters, and that actually is year-round, despite our weather. We have great schools. We have public transit that runs right through campus. Our housing is relatively affordable. That's in the top right, a picture of the transit right through the middle of campus. And then we have an assortment of maps showing different levels of bike routes and bike trails throughout downtown, around all of Minneapolis, and throughout the state. In the middle of the slide, there is something that not everybody has, and that is a map of the Skyway system in Minneapolis, where you can walk from one end of town to the other without actually ever going down to the street level. So our goal is to train outstanding ABR certified clinical radiologists to prepare residents to be the future academic and clinical radiology leaders of Minnesota and beyond. So for the last 4 years, we have had 100% core and certifying exam pass rate. And last year, nationally, the rate was a bit lower than that. The reason there's a little asterisk here is because the core exam in 2020 was delayed and has not been taken yet. We have 3 healthcare systems, 4 hospitals, 2 outpatient centers, and a research center. You will see a breadth of pathology, diverse patient populations, different levels of acuity, and learn to practice in a variety of different business settings. These are photographs from our university campus. This is our clinic and surgery center in the left upper hand. The left lower hand is the adult hospital, and you can tell it's kind of a mock-up of what it's going to look like when some renovations are done on the front end of the building, which is almost complete. The bottom right corner is the pediatric hospital. You can tell because it's purple. And the top right corner is the Center for Magnetic Resonance Research. Hennepin County, we are very lucky to partner with this level 1 trauma hospital. The middle column has pictures of the radiology faculty, and the leadership for the transitional year is on the top left. The photo on the bottom left are residents from the transitional year program last year, including our residents and other transitional year residents. They have their surgery and clinic center as well on the bottom right, and the hospital itself on the top right. During radiology rotations in the first year, they're 4 weeks in duration. It gives people a little bit more time on the ground before changing specialties. We rotate through all the basic radiology rotations. There's a QI project that is done, and there's a little bit of buddy call in the spring to get people used to knowing what the pager is like. That's not independent call. In the R2 through R4 years, there are 3-week rotation blocks, including advanced rotations, electives, call at both Hennepin County and the U, AIRP, and mini fellowships to get people prepared for their fellowships or get extra experience in something they're not doing their fellowship in. So we've made adjustments due to COVID. Dr. Dietz and I spent a lot of time talking about offices and where to put workstations and how to keep people adequately distanced. So you can see the distance between the people in the reading rooms is quite adequate at this point, and a lot of our reading rooms have been transitioned to single workstations in a small reading room to keep everybody safe. We spent a lot of time outside, including over the lunch hour, which is the picture in the center. Our didactics are now on Zoom. Having so many different training sites used to make conferences logistically challenging, but Zoom has fixed that, and it's actually easier for us all to get together for our conferences now. We have noon conferences, journal clubs, our chairman's conference, physics conferences, series for the first years that are aimed at getting them going and getting them ready for call, interdisciplinary conferences, and then our main conference is on Wednesday mornings as kind of a long block of time is our core conference series. We have great resources and benefits, multiple online resources, StatDX, Rad Primer, Core Physics Review, and hundreds of books on Elsevier Clinical Key. We also supply a hardcover textbook for your first year. There is paid leave for AARP. Our first years have attended the ACR conference every year. We'll see how COVID affects that, but attendance is what we're looking forward to, and that's sponsored by the, oh my gosh, I'm blanking on the name. The Alumni Society, no, it's MRS, Minnesota Radiologic Society. And there's also travel for one research presentation during the residency paid as well. There's 6 weeks parental leave, and that's throughout the university. There's an educational allowance and good mental health resources. We have worked hard to try and figure out ways to come together as a department. There are new and older mentorship programs going on. The Curie Club is the picture of the 6 women in the center of the slide, and that is a club for gender equity in radiology. We have R1 and R2 mentorship pairs. New this year is a mentorship house plan that includes faculty and all levels of residency with some inter-house competition, Hogwarts style. And then of course there's research mentorship on an individual basis. We have a resident-run wellness committee. They advocate for the residents' needs, plan events, and have even stepped into the realm of fundraising recently. Pre-COVID department events, as Dr. Hoven had mentioned, was included the golf tournament at Dr. Dietz's expense, class breakfasts, happy hours, and a family bowling party. We hope to be able to get back to those types of things as soon as possible. Many of our residents stick around. 67% choose to do fellowships in Minnesota. The fellowships outlined in gold are done here. And these are the last 2 residency classes. People tend to get their first choice for fellowships coming out of our program. And then the fellows also tend to stick around. We've had multiple fellowship members from the last 2 years stay on as faculty here or at Hennepin County and maintain their connection to the residency training program. Thanks.
Okay, thank you, Dr. Holm. I'd like to transition then to invite Dr. D'Souza to present on the IR front, please.
Great, thank you. Okay, can everyone see my screen?
Looks good.
Okay, good. All right, hi everyone. I'm Donna D'Souza. I'm the IR Residency Program Director. So I'm going to give you an overview of the IR-DR residency here at the U of M. So to start with, and you've already sort of virtually met us. So the picture, these are the people that run our IR and DR programs. On the left is me, the IR Program Director. Dr. Tala'i is our IR Associate Program Director. Dr. Holm, who you just heard, is our DR Program Director, and Dr. Hoven, who's moderating tonight, is our DR Associate Program Director. And in addition, Dr. Holm is one of our Associate Program Directors for IR, and I'm one of the Associate Program Directors for the DR program. And so this sort of illustrates the fact that we run both the DR and the IR program together, and run them very closely, and everybody is sort of mixed in a very coherent fashion. These are our program coordinators, Morgan Goetz and Shari Johnston. So the structure of our residency is, this is the generic structure for any IR residency. There is an intern year, And in our program, it's a transitional year that is built into the program as a categorical year. It's similar to the DR residency transitional year, with a little bit more of an IR focus. And then PGY 2 to 4 focuses on DR, and PGY 5 to 6 focuses on IR. And so the rough schematic looks like this. So PGY 1 is the TY year. PGY 2 to 4 is roughly 11 months of DR and 1 month of IR. PGY 5 is roughly 2 months of DR and 10 months of IR, and PGY 6 is 10 months of IR, a month of ICU, and then we're working on a vascular surgery rotation as well. But in actual fact, in PGY 2 to 4, our IR residents are getting a little more than a month of IR. It's probably right now about 6 weeks in their junior years. So I won't talk about the DR aspect of our program because Dr. Holmes done a great job covering that. So in terms of the IR part of our program, the types of procedures we do really cover the entire range of interventional radiology. Our trainees do a lot of peripheral vascular interventions, so angioplasty, atherectomy and stenting, thoracic and abdominal aortic endografts, varicose vein work, DVT and PE treatment. We are a big PERT center, a PE response team center, so we do a lot of pulmonary thrombectomy and lysis. We are a big oncology center, so we do a lot of TACE, Y90 and ablation, men's and women's health, so fibroids, varicoceles, prostate and embolization, and then a lot of acute bleeds and trauma embolization as well. We are a liver transplant center, so we have a large cirrhotic population, so we do a fair number of TIPS and a little bit of BRTO. It's really fallen out of favor in the IR community. We have a pediatric hospital where we do a lot of vascular malformation treatment. And then there's a bread and butter IR procedures that we do, so dialysis work, tunneled lines, vertebroplasties, feeding tubes, nephrostomies, biliary work, biopsies, drains, and so forth. And so there really is, our trainees are well trained in all aspects of IR. These are the sites where our trainees work. They spend most of their time at our parent hospital, which is University of Minnesota Medical Center, about a quarter of their time at Hennepin County Medical Center. This is in the IR years. The Hennepin County Medical Center is our level 1 trauma center and is where they do a lot of peripheral vascular interventions and get experience with endografts. And then the University of Minnesota Medical Center is our big oncology center and where we do a lot of our TIPS and other portal hypertension interventions, including things like portal vein recanalizations and so forth. And then the Children's Hospital is where we do obviously our PEDS intervention. And then we all have outpatient. We run our own outpatient clinics in this big building here, which is called the Clinic and Surgery Center. And so all our trainees spend a fair bit of time in our outpatient clinics with us as well. These are the 8 faculty that are full-time interventionalists. I should also mention Dr. Dietz is an interventional radiologist as well, that predominantly does administrative work, but does help us out where we need. And he's the chair of our department. So there's actually 9 of us. And then at Hennepin, there's 4 full-time interventionalists. And all of us, we all know each other. We all get along really well. Our clinical team is very large at the U of M. So we have 8 full-time faculty. We have 6 IR physician assistants, and 1 is an RPA, 2 nurse practitioners, 2 nurse coordinators. We have many of our own schedulers, and this is a combination of the pediatric and adult side, and then about 20 IR techs and 22 IR nurses. And then at Hennepin County, it's a slightly smaller department. There's 4 faculty, 2 PAs, a scheduler, and 8 techs and nurses. And we all work very closely together. The general rotations and duties for our IR trainees in their IR years. So it focuses on there's procedures, which forms the bulk of what we're trying to teach you, and then there's our trainees are involved in our outpatient clinics and performing inpatient consults. There's a mandatory ICU rotation. We're working on a vascular surgery rotation, and there's also protected research time. Other learning activities in the IR realm. So we have a weekly didactic lecture series for our IR trainees every Wednesday morning. There's multidisciplinary conferences that they attend with us depending on what their schedule is. So there's vascular conference, liver tumor conference, and so forth. Our group does a monthly journal club, a monthly M&M session. We have vendor training sessions as well, where the vendors will come in the evening, usually around 5:30, and they'll bring their products in to train our trainees. We have one vendor on any given evening, and we do about 10 or 12 of those every year. They actually bring food, so they'll bring dinner, and then they set up their products. They'll bring like endographs, for example, and a simulator, and then they set it up in a room at the hospital that we have, and then you can go and learn about their products. Or then they'll bring coils, stents, and whatever the depending on the actual device company, and they bring these. They bring a lot of their equipment in. The nice thing is that Minnesota is actually a lot of the headquarters and the head offices and factories and plants for medical device companies are in Minnesota. So a lot of the simulators and things are actually housed here. And so our reps can bring them in for us. We like to send our trainees to some of the vendor sponsored training courses, and then we expect our trainees to come with us to national meetings. So our faculty are very involved in SIR and the guest meeting in particular. Many of us give talks there and are on committees, and our trainees will come with us to those meetings in particular. So Dr. Holm did go over the benefits. This salary structure is probably a year or two old, I don't know, but this is roughly what our trainees get paid. And then we have full benefits, an educational allowance, full insurance, 4 weeks paid vacation, 2 weeks sick leave, and maternity and paternity leave are both 6 weeks in our department. So why choose University of Minnesota as your training site, or consider us as one of your top choices? So for IR, we have very high procedure volumes. So our current residents are doing about 800 to 1,000 procedures a year, and that's all procedures in their IR years. We do have the full breadth of IR cases, so peripheral vascular, oncology, non-vascular, bread and butter cases, pediatrics, and so forth. We are a full clinical service, so we are a consult service on the inpatient side, and we perform inpatient consults, and we run our own outpatient clinics, and we admit patients as well to the hospital. We have a a strong research focus. We expect all our IR trainees to engage in research, and we try and engage them early in their PGY 2 year. And so when they come, into the IR residency and engage in longitudinal projects, and then in the last 2 years, IR research is something that we give protected time for. Our institution, and even in our department, we have leaders in medical device innovation. So if any of you have a bioengineering background or interested in device innovation, we are a great place to be. We have the Earl Bakken Medical Device Center that is where they actually have medical device fellowships, and so the fellows in that fellowship are always looking for ideas to help us to medical devices and new ideas to innovate. And so sometimes, we work with them. And then some of the faculty themselves actually are particularly interested in this and have patents on medical devices. We do have a strong affiliation with the medical device industry because a lot of the headquarters are here in Minnesota. We have an excellent DR program with high case volumes, as Dr. Holm showed you. We do have a 100% pass rate on the board exams, as Dr. Holm mentioned. And we do give protected study time for 3 months prior to the board exam. Our trainees get half a day every day to study for 3 months prior to the board exam. Other reasons, one of the things that is not universal is non-invasive vascular imaging as part of radiology. So there are a lot of centers where the vascular ultrasounds are read by cardiology and vascular surgery, but here at the U of M is all read by us and the CTAs and MRAs. So from the IR standpoint, our trainees are well trained in interpreting vascular imaging. We do have a good relationship with our referring providers. I don't know if it's a Midwestern thing or it's our institution, but generally we get along. Everybody tends to get along at the university, and so we have good relationships with surgery and other specialties. And overall, our department in particular, and also our multidisciplinary colleagues, form a very collegial and friendly work environment. It's very unusual to find sort of the toxic people and people that kind of butt heads with each other. We tend to try and collaborate as much as we can with each other. As Dr. Home mentioned, we have a strong support for women in radiology and women in IR. Our Curie Club is a club that we, prior to COVID, we were meeting face to face, and also the women TY residents and IR and DR residents and faculty, we would get together, and we'll do it, once COVID is over again, and we get together a few times a year and do fun things. We do have strong support for inclusion and diversity. We have our own active inclusion and diversity committee that is dedicated to ensuring that we are very inclusive in our hiring of trainees and faculty from diverse backgrounds. If you are interested in global outreach, we are strongly affiliated with a hospital in Tanzania that has a medical school, and so every year certain faculty and some of the trainees will go, the residents and fellows will go to Tanzania for usually, I think it's a couple of weeks around January. And the other thing I like a lot about our program is that it's a categorical program. So you match once and you move once. The DR peers are in the same TY program as our IR residents, and so you get to know them very well and build relationships early. Our TY residents are treated well at HCMC. It is a year that is well liked and always gets good reviews, and that's very important to us. The IR residency, so we get to help shape the TY program. So the TY program is independent and has a very strong program director, but we do get to help shape it to some degree. And what we've been able to do is make it a little bit more IR focused for our trainees. And I think that's it. Maybe there's one more slide. That's my last slide. So thank you very much.
Dr. D'Souza, there was one question in the chat about neuro-IR exposure.
Let me just get let me stop. All right, there you go. There, I can stop screen sharing. So neuro-IR, so neuro-IR is a separate department. So we have our own neurointerventionalists that comprise of some neurointerventional radiologists and endovascular neurosurgeons. So they are separate. But if we have any trainees that are interested in neuro-IR, or for example, they are in their last year and they get a job where they know they're going to have to do stroke work and carotid stenting and things like that, then we are able to arrange a rotation, a neuro-IR rotation for sure. So we kind of leave it right now as an elective, but there certainly is that opportunity.
Okay, good question. Thank you for posting that out there. Please feel free to continue to post questions. We'll round up one more overview with Dr. Young. Like I said, feel free to post questions along the way, but otherwise I'll hand it over to you, Dr. Young.
Hi, everyone. I'm Matt Young. I'm a hospitalist at HCMC, which again is across the river from the university. It's a very quick light rail trip over. So in fact, it's the most efficient way to get between the hospitals is because the light rail drops off right in front of each of our facilities. So I've been at HCMC. I did my internal medicine residency there about 10 years ago and have been part of the transitional year program for the last 8 years. I love this part of my job for a few reasons, but the most important ones are the transitional year residents that I get to meet. It is so fun and so rewarding for me to see 25 medical students or recent graduates or new doctors go from acting like medical students and thinking like medical students to becoming doctors over the course of the year. It's so fun seeing that over and over and seeing some of the interesting, unique pieces for each person, for each resident's year, as well as the things that are common. And so a lot of people, have really enjoyed the start of it because they came in with a lot of energy. Then they feel like they're not making progress halfway through their intern year. And then almost uniformly over the course of the entire year, people come to me at the end of the year and just say, I looked back on the year and I just really loved it. I see how I have changed as a physician, and I'm so excited now to begin my subspecialty, my specialty training in radiology, anesthesia, ophthalmology, and dermatology and stuff. So our program, I'm just going to pull up my PowerPoint here. Give Give me one sec. All right. You can see that? Okay, so Hennepin County Medical Center is the county hospital. It's located right in downtown Minneapolis. If you sort of overlie our patient population at Hennepin County Medical Center with the sort of low and underserved and vulnerable populations in the city of Minneapolis, as well as the county of Hennepin, which is where Minneapolis sits, they match almost exactly. So we deliver really high quality care to patients that otherwise wouldn't receive it because of issues with insurance or other things. And so we all take a lot of pride in delivering the level of care to patients that we think really deserve it. The transitional year at Hennepin County is very old. It's older than me, and I'm getting up there in years. So there's been a transitional year program at Hennepin County, I think, since 1982. It's one of the biggest in the country. We have 25 interns per year. Over the years, what's happened with our program is it used to be 25 freestanding spots for transitional year residents that would then branch off into other residencies. We've developed paired programs with radiology and anesthesia over the last few years in sort of smaller ways. And then what was happening was we were delivering really well-polished, well-trained interns to their specialty programs, and our paired model then changed to from partial to full, in the sense that we train all of the interns going to the diagnostic and interventional radiology programs over the last few years. We used to have half of the, we used to have the about half of the anesthesia residencies interns, and it became very clear over the years that we were sending residents that were much more prepared for their training. And so what's happening this next year is that we're actually using all 25 of our spots in a paired way, where we're going to have all 10 radiology and interventional interns. We'll have all 10 of the anesthesia interns at the University of Minnesota, and then we're pairing our last 5 spots with ophthalmology. And so we're transitioning from a transitional year to an intern year for these 4 different residencies next year. And we're excited to do that because normally our philosophy on transitional year has been a very broad-based experience where you do a lot and see a lot and learn a lot as a growth progress model. And now we're going to start working together with all the 4 program directors that we're paired with to tinker with it and make it even better for each individual trainee. This is our group. I think we've had our pictures shown on the other 2 PowerPoint slides, but Dr. Pace, who's here, shares the love of the transitional year residency, specifically because we get to meet so many cool people through it. It was fun to see her hop on this call and see some old faces of our interns and see her face light up and just be excited and ask everyone for updates and stuff like that. So it's just really fun to get to know all of our trainees. I've sort of mentioned it already, but I can't emphasize it enough. Hennepin County Medical Center takes care of poor and vulnerable patients, and we do it well. It can be very rewarding. It's also very, very hard. And so I think it's really important that anyone that's going to spend an entire year here plus a quarter of their residency to just recognize that this is the type of county hospital that we don't just mail in the clinical care we do. We strive for the best for every one of our patients. And sometimes that means we succeed, and sometimes it means we don't, in the sense that we can't control everything in everyone's life. And so there's patients that end up right back on transitional year interns service 2 days after they thought they had really made a connection and really set up a good discharge plan. And then we just try again, and we try and connect with our patients in really cool ways. We don't hug all of our patients because that would be kind of weird, but this was just a cool article in the local newspaper a couple years back about an innovative program that we're doing to really try and address opioid use disorder throughout our healthcare system, including the emergency department. As I mentioned earlier, I think one of the things that we really strive for is a broad experience. So I'm not particularly interested in making trainees good radiologists. I'm interested in making them really good doctors. And so I think some of the best radiologists that I work with at Hennepin have a very deep understanding of what my job is and what my role as an internist and how that's different from what Dr. Pace is calling a radiologist to ask them. And so we want to expose our interns to a lot of different settings and a lot of different specialties so that when you get called, you know how you can best help that provider. The specific rotations are here. I won't spend a ton of time on the details. I'm more than happy to take questions from anyone about it, but in general, there's two blocks of internal medicine on the cardiology or general medicine units. We try to get anyone that's interested in the MICU a rotation there, but that's a little bit tight, and we generally reserve those for the anesthesia interns. We get 2 months of surgery at our level 1 trauma center, and usually one of them is more on a trauma general vascular service, and then the second one is more on a subspecialty service. For IR specifically, we try and get IR into paired with our vascular surgeons for at least one of these months specifically. Emergency medicine is 2 months. It's a pretty standard emergency medicine rotation with shift scheduling. They do a pretty nice job of making decent schedules in the sense that you don't go from night to day to night, but try and kind of smooth into a night to afternoon to evening to night to daytime kind of thing. 2 months of radiology. So the DR interns are going to do a kind of potpourri of different things over the course of those 2 months. Our interventional radiology interns will do 4 weeks of diagnostic radiology, kind of a potpourri across, I think, ultrasound and chest x-rays and other things, and then spend a month with our interventional radiologist for their second month. Pediatrics, neurology, OB-GYN, psychiatry are parts of our program that have been in it for decades. We have really good educators, really good trainers and teachers, and get feedback from the residents that they gain and learn stuff from these rotations. So that's the reason that we have such a broad experience, is just that we have the educators and the trainees the residents, the senior residents to do it. And then 1 month for a quality improvement / kind of research elective to allow people both to get a breather from a pretty rigorous year and also to start working towards the research projects that they'd like to do in the future. In addition to like every rotation that you're on, working with categorical residents and having access to those residency learning opportunities, we really try our best to make the 25 transitionals a chance to get to know each other in such a unique and challenging year. And so we spend a decent amount of time. Sometimes it's learning about medicine, the types of things that cross over many specialties. We spend a ton of time in our clinical setting as well as in some didactics learning and gaining expertise in ultrasound. And also sometimes we just hang out. And so doing artwork and sharing reflective pieces over the course of the year of what we're learning and how it feels to become a doctor is important. I had to change this picture because I think Tara stole one of my other ones, so I flipped it to this goofy one. This was a fun night for all of us. I think that's all I had. I just wanted to give Iwe a shout out. She made piñatas that look exactly like us and actually is literally dressed the same as Katie, is how in tune to things Iwe is. If anyone has any questions for me, you can feel free to email me there. All right, thanks.
Thank you, Dr. Young, for that. It's really fun to see some of those pictures from before they get to our door. So we had some questions in the chat. Some of them have been answered so you guys can see, but one of the questions talked about QI projects for our residents. And Dr. Ricken, do you mind just giving an overview of what you talked about in the chat function? And welcome.
Thank you. Yeah, I'd be happy to talk about it. Every year, all the R1s pair up with at least one faculty member and see a QI project through. And they are all very good projects for the most part. You know, some QI projects are naturally better than other QI projects, and the ones that rise to the top make it to the larger venues. As I mentioned, you know, we could talk to Dr. Stuck about her experiences. Her QI project made it to ACR, and it's still ongoing, which is what we hope for all of our QI projects. Sometimes they're carried on by the same resident throughout the course of their residency, and sometimes they're handed down from, you know, one resident to the next as everybody goes through this cycle, learning the concepts of taking on a QI project. But it's a fun part of the year, and a lot of faculty do get involved in it. And then the annual forum for the presentation of those and other research projects is a lot of fun every year.
So Jeff,
Yep.
what subspecialty do you practice?
Mammography?
I don't think so.
Thank you, Dr. Ricken. So another question, we'll kind of transition now. This is sort of the very informal, hopefully organic conversation of just taking your questions from out there. We'll do part of this session with the faculty online, and then at some point we will all jump offline and you will have the floor to discuss whatever you'd like with our residents exclusively. So one other question that popped up that we might address now while we're on, one of the, someone out there, Ben, a good question, asks about moonlighting opportunities. And I see some of our residents here that are moonlighters. So do you mind talking a little bit about that? Where you moonlight, what you do?
I'm moonlighting right now. But there's 3 sites we go through. One being St. Paul Radiology, which is where I'm at right now. And then you also have opportunities through the outpatient center at the U, at CSC. And you also can go to the Minneapolis Clinic of Neurology to moonlight. There's a lot of opportunities, but generally you aren't able to do it until about our 2 year. But lots of opportunities.
That's good. What about you, Nicole? What do you like about the moonlighting opportunities?
I like the money. No, I actually study a lot on my moonlighting, when I'm moonlighting. There really isn't much. So our moonlighting consists of contrast coverage. We're not reading anything. We sit there, and if something happens related to contrast, or I don't know, a vasovagal or something with a patient, you go, you evaluate them, and usually everything is fine. So most of the time you're sitting there and you don't have to do anything at all, and you just study, or some people watch Netflix or whatever. So I like being able, it's like a free study time. I get paid for it.
I know one question that comes up for our interview season, and since at the beginning of the poll we had kind of a breakdown of both, you know, viewers out there interested in both DR and IR, maybe for either Dr. D'Souza or Dr. Holm, you know, how do we handle applications coming in for both IR and DR? Do either of you want to comment on that, please?
Yeah, I can start. So, you know, I know that some residents are sort of concerned about applying to both and how to handle both. And I think I just want to put it out there that you should apply to both. You know, it's just, and we expect that people who are in IR will also apply to DR, because you can do IR through a DR residency, either through ESIR, or you can just finish the residency and then go on to do the 2-year independent pathway. So we expect that you're going to apply to both, and it's not a secret. We don't look down upon it. We don't, there's no judgment. We just know it's going to happen. And if I was in that situation, I would do the same. The way we handle applications is that we review them separately. We just, like Dr. Holm and Dr. Hoven will review the DR applications, and Dr. Tully and Dr. I review the IR applications. And we just review them separately as though they were just as separate residencies, really. That's just how we review them. And we interview, you know, we basically choose our short list of interviews based on the merits of the application to that particular program. And then we are planning on sort of combining the interviews. And I think Dr. Holm can, for people who have applied to both that end up on our shortlist for both, we can, Dr. Holm can explain a little bit more about what her plan is for, she spearheaded our sort of joint interviews for IR and DR.
Sure. I am going to be participating in all of the IR interview days. So since we have representation from both IR and DR on those days, if I'm jumping the gun. If students have been invited to both interviews, then we can use the IR interview day for both programs. Now that means a lot more if you have to fly to your interview day, and maybe a little less since they're virtual. But those who are interested in only interviewing once and have been invited to both programs can have just the IR day, and we'll use it for ranking separately for both programs. People can feel free to sign up for IR separate from DR and interview twice. There's no problem with that. It's just, we know you are all very busy and you have a lot of things to juggle and a lot of things to fit in. So if it works better for you guys as the candidates to just have that one day be covering both programs, that's fine with us. It may be a little logistically complicated because the IR interview days start a little bit later for us than the DR interview days do. So if you're planning ahead and you're applying to both, you may want to pick one of the later DR interview days if you get that interview invitation first.
Sounds good. Thank you guys for answering that. One question that came up is, what is it like being a DR resident? And so I thought maybe we could have one of our first year residents chime in and then maybe one of our senior residents start. So maybe Yue, what has life been like for you coming from transitional year to now an R1 year? Or Rena, either one of you guys.
It's been great. I can actually just kind of briefly describe my day today. And hi everyone, I'm Iwe. So today, I'm currently doing body imaging at Hennepin County Medical Center. So we start, around 7:30 in the morning. And there was actually a STABE conference that was going on, and they said I could, let's see, I don't know if you can still hear me. They said my internet connection was unstable. But they actually said I could either, attend the conference, and there were just a couple studies on the list, so I decided to try to take a couple studies and see if I can get through them since I'm still learning as a first year. And then my staff would actually go through the studies with me, so we're pretty spatially relocated, so there's about 3 of us in the body imaging room, and I feel pretty safe in the area. And he would actually go through the studies with me, and also over lunchtime, we would be allowed to go to the cafeteria and get food, and I actually ate outside today. It was really beautiful outside. And then we had a noon conference from about 12:15 to 1 o'clock with Dr. Punjabi, the chair of radiology at Hennepin County, and that was incredible to kind of just go through the simple cases. And we had transitional years with us and also medical students with us. And then in the afternoon, just continued going through a couple different studies, and then also learning from the senior residents and staff as well throughout the day. It was great.
Very good. Any other first year comments or some of our senior residents? I see some R3s online. Ben or Kevin or Chad, Shannon.
Sure, I can chime in. Can you hear me okay?
Yes.
So hello everyone, my name is Ben. I'm a 3rd year resident. And as far as a typical day, I'll echo what Yue said. On a normal rotation, which is a non-call rotation, generally we start at 7:30, whatever number of studies are on the list, we'll start reading them, and then at some point we'll staff out either over Zoom or over the phone. Pre-COVID, it would be a combination of looking back and seeing what the attending had changed to side-by-side teaching at the workstation. And then when we take call, we're either at HCMC or we're at the U, and generally those are split up into 3 shifts, sort of a late afternoon shift, an evening shift, and then an overnight shift. And as an R2, 3, and 4, those are in 3-week blocks. And then again, as people have said, on Wednesday mornings, we have dedicated conference for didactics.
Very good. Anyone want to comment on, the faculty resident ratio? So if you're on a reading, particular rotation, how many faculty you can see as far as staffing out goes? Any of our faculty want to take that question?
In Peds, we're usually 1-to-1. And during COVID, it's one faculty reading from home and staffing out over the phone or over Zoom or over the chat box, and one faculty in-house spending a lot of time coming and going with the first-year resident into the fluoro room to do fluoro procedures.
And then neuro, I'll say we have anywhere from 3 to 5 faculty on staff at any given point in time. Usually it's in the 3 to 4 range, and 2 to 3 residents and 1 to 2 fellows. So close to 1-to-1, not exactly, but in that neighborhood.
It's about the same in IR. So we have an outpatient rotation, which is one-on-one between faculty and resident, usually a senior resident. And that would be for reading non-invasive and doing outpatient procedures. And in the inpatient workroom, there is usually 3 to 4 faculty, 2 fellows, and 1 resident. So I think it's about 1-to-1 in IR as well.
Dr. Church, do you mind commenting on our breast section?
Hi, I'm on. I'm a breast imaging radiologist, and it's a little bit different in breast imaging just because we're not acute like body and neuro and other things, but we do have numbers that all residents have to go through to attain when they graduate. So we get residents maybe once a year. And so therefore we tend to have more residents per faculty at the same time. But we make it happen, and we try to make sure that everyone learns and knows what they need to know, whether to either pass their boards or be the best imaging radiologist in the future.
Thank you. Someone asked about any rotations outside of the 4 sites mentioned. I think those are kind of our core sites for rotations in our program. This year during COVID time, some of our residents spent time at our outpatient imaging facility and surgical clinical center up at Maple Grove. But most of our residents spend most of their time at those core hospitals that we described previously. One thing that I'm not sure if Dr. Holm mentioned, but the VA Medical Center is also one of those spots. I think she did touch base on that. I have a question on, medical students who want to get involved in our program. Away rotations kind of went away. Do you guys have any advice out there? Maybe, Dr. D'Souza, Dr. Holm, on how people can kind of get to know us beyond this call? Any advice?
I can speak for the IR side, because I think one of the questions is, do we accept 4th-year medical students that would like to do an elective rotation IR-DR? So right now, unfortunately, we are restricted in having people do an in-person elective. I mean, normally, yes, and if we weren't in the middle of a pandemic, yes, absolutely, you could do an away rotation with us. But right now, we're only allowed to have University of Minnesota medical students do an IR elective with us, which is a 4-week rotation. And then outside of that, we actually have a virtual rotation. So if anybody is interested in doing a virtual elective for IR, you can actually sign up through VSAS and do an elective. And what we do for that is we have didactic lectures every day from the faculty. You get to meet the residents, like a meet and greet. You get to meet myself, you get to meet Dr. Tyler E and ask questions. And then you participate in our morning rounds and our weekly didactic lectures for the senior residents. And what else? Yeah, I think that's the main gist of it. And so you can sign up for a virtual elective through IR. And there's also one for DR. Dr. Holm can talk a little bit more about the DR side of it.
So the virtual elective for DR did not make it through the VSAS process. There was a hang up regarding whether there would be the potential of displaying health information, PHI. So the live case conferences and that sort of thing that are part of that meant that it couldn't go into VSAS. So we do not have outside residents rotating in DR at this point. And the university has, in addition to the mHealth system, has put a hold on observers until the end of January, which unfortunately puts it in a category of being kind of too late for the timeline that the current MS4 students would be looking for rotating with us. If people would like to email me, I'm happy to have individual chats with people on Zoom. I'll put my email up here in a second. That's basically what we've been doing to get to know people who are reaching out, is just setting up, you know, a 30-minute time frame and having a conversation about the program. We have found that having outside medical students rotating in our department, like a lot of our matches came from that last year. It allows people to get to know us. It allows us to get to know people. I feel like it's really heartbreaking for me this year that we don't get to do that. We don't get to meet people from outside our own institution. And, you know, even right now, the in-person rotation for DR is quite limited in the amount of days that our own medical students are in the reading rooms with our faculty and our residents. And the majority of what they're doing is actually online as well. So it's all around a tough time to get to know radiology. And I'll put my email up.
I'll just piggyback on what Dr. Holmes said too. Please, for anyone that's interested in the IR residency, Dr. Tala'i and I are happy to meet with you as well, like do a Zoom chat or a phone chat, and we can put our emails up somewhere as well. But we're also, so our email addresses are also on the website, on the education website, if you ever want to find it again. And just please reach out to us, and we can chat by email or Zoom or telephone.
Someone posted a question. I'd like to rephrase it a little bit, and I'm going to start by asking Dr. Dietz. Someone wanted to know what we're looking for in our applicants, and I'd like to rephrase it by asking Dr. Dietz, what do you think, what kind of residents are successful in our program?
So, you know, I think that to be successful in this program, we are looking for self-starters. We're looking for people who are eager and excited to be a radiologist and know that even if we try to spoon feed them for 5 or 6 years while they're here, if that includes a fellowship, the people who are successful establish a very strong ethic of teaching themselves and then taking advantage of the resources that they have for the 4 or 5 years that they're a radiology resident. Because trust me, this education and learning process goes on throughout your career, and the sooner you get into that, on the more global side, I will tell you that I, from Ohio, so yes, it's the Ohio State University, but I moved up here for the program because the program was very strong, remains very strong, broad strokes, but I actually fell in love with the city, and obviously I'm here a few years later from my residency program. But again, what we would look for, I believe, are people who are excited about education and show a track record of success and self-motivation. People like you, Noelle.
Thank you. So there's a lot of good questions coming on through chat. So thank you guys. Any comments on call for the residents who are taking call? Specifically, what does overnight call look like? And for those who are the R2 class, how has that transition been from the R1 year to taking call? So let's start with first our senior residents who have taken overnight call. And maybe let's hear from either Chad, one of our chiefs. Alyssa, if you're around, maybe start with Chad. Overnight call, are you alone?
Sure, yeah. So so we take overnight call at 2 different sites at HCMC, which is our level 1 trauma center. And on those nights, you are alone. So you always have backup support from your staff that are available for you to page. And there is a service, a Nighthawk service that does put prelim reads in, but overnight you receive a lot of trauma cases where you physically go to the scanner. Oftentimes there will be a trauma team and other consultative services there, depending on the level or severity of the case. And you're kind of giving them your preliminary impression and potentially asking for delayed images on the scan. The number of cases that you read on any given overnight shift there can vary depending on whether it's summer or it's the winter. Summer is very trauma heavy. It can be very busy, but it's it's a great opportunity to hone your skills in looking for trauma patterns. And then overnights at the university is that's our tertiary quaternary academic center. It's a little different now, where we're reading mostly cross-sectional inpatient studies and plain films. A lot of the overnight cross-sectional stuff, ED stuff, has been shipped over to another Nighthawk service. So it's a little bit slower paced now, but certainly more complex cases. And both are going to teach you, independence and efficiency.
Thank you, Chad. What about like Kevin, maybe Shannon, if you've taken call yet? How was the transition with buddy call into taking call independent as an R2 radiology resident?
Yeah, it's been really good. I think, so starting in like January of your R1 year, you'll start taking buddy call shifts. So after like a normal work day, during the weekday, you'll say from like 4:30 until 9, I think it is. And you'll be kind of like it sounds, like a buddy on one of the on call with one of the residents that's on call. And you're kind of acting like a second person on call, just reading studies and maybe, checking them out with the resident there and then sending them to the staff that's on call. And so it kind of just gives you an opportunity to see what it's like to, see what kind of cases come in after hours and start taking cases and not necessarily, staffing them out with one of our staff sitting right next to you. So you'll do a handful of those buddy call shifts throughout the kind of late winter and spring of your R1 year, and then start taking some independent call shifts at the beginning of your R2 year. And so I've done a handful of the independent call shifts now. I haven't done a full call block yet, but I would say by the time you get through the end of your R1 year and have done some of those buddy call shifts, whether or not you feel like you're ready, or you are, I think, ready to start taking call. And so it's kind of a good way to ease you into that process of taking call by yourself. And I think it's a good system that we have set up. So.
Kevin, when was your first day of calls, the second year?
July 4th.
And look he's here, folks, smiling,
alive.
Talking about call. I think Dr. Young in the chat made a really nice comment about, our residents get exposed to call at the academic university setting. So, complex cases, we have an ER as well, where we're covering ER and inpatient. And then they also take call at Hennepin County, which is a level 1 trauma center. And so the trauma that's coming through, they're getting very comfortable with going to the scanner, looking at things live as the team is waiting to hear, any acute findings. In the beginning can be, a little bit, scary, but, this is a hospital that you just spent an entire year at. So you have a lot of familiar faces, a lot of ER physicians you've worked with, your fellow interns that are now senior residents on the medicine or surgical teams. So that's another really nice feature of kind of having both call experiences. You're really prepared for a variety of acute care so on call. So, and I think, you're not alone, as Chad mentioned. All of us faculty, are readily available by pager. I know when I'm on call, I give the resident my cell phone number. I'm like, page me, but I prefer a call to my cell phone. I prefer you having both just in case. And I think all of us would agree, those that take call, we are always welcome, whether it's 1 a.m, 5 a.m. I still remember calling Dr. Dietz at like 3 a.m. as an early second year call taker. And it was just fine. So thank you, Dr. Dietz.
So I was nice to you?
Yes.
Good.
So Let's talk a little bit about, there's a question about the DR curriculum when you're an IR, DR integrated resident. Any comment on that as far as, you know, which rotations do they get less of if they're going to be an IR, DR resident? Any comment there?
You can't short mammo and you can't short nukes because those have hour and week requirements that have to be met. So those two rotations are protected in that way. The DR fourth years would be taking mini fellowships. So they might have a block of 3 months of neuro or 3 months of MSK. So you would be taking it more like mini fellowships in IR. It's kind of, you're pre-selecting what you're doing and it's IR instead of the mini fellowships in the other areas. Does that make sense to you, Dr. D'Souza?
Yeah, because fourth year really is, it's often a mini fellowship year. And so the IR-DR residents still get comprehensive training in all aspects of DR in the 3 years. And then they actually have to continue that in their PGY 5-year anyway to complete their mammo and nukes training. And also they still have to do a little bit of call, so they get ongoing exposure to DR.
Thank you. Yeah, we've got 2 more questions on the line here. Maybe we'll answer these 2 and then we'll give the attendees and then the residents some time to ask questions among themselves. But one of the comments or questions I have, I'm going to ask Reza this one. You know, any comment on research experiences that our residents can have? I know IR and maybe even neuro too, pretty active in the research realm. So any comment on that?
Yeah, I think overall we have a lot of very avid researchers in our department, not just in IR. I mean, all around. We have the CMRR right around the corner, the residents who are deeply interested in more advanced research. As much as I can say, it's as good of an environment they can have in CMRR. Also, with our clinical faculty in IR particularly, we have a few of us who are spending a good part of our week doing research, and they're presenting in many national conferences, also publishing on a routine basis. Some of us have very niche areas of interest for research. Myself, I'm interested in musculoskeletal interventions specifically, from embolization of osteoarthritis all the way down to, to more, bone meds and what have you. But I think when I look at the areas that anybody could do research with us, it could start from something small like a QI project all the way to something very advanced. We have residents who work with us with one mentor faculty throughout the residency and start and finish something as big as a clinical trial. So I think the range could vary depending on what they bring, the residents bring in, and what they want to get out of this. Depending on their goals, they can do a lot of things.
I'll speak up for neuro since I was pinged there. Yeah, the neuro faculty is pretty engaged in research as well. At our monthly division meetings, everybody brings up their projects that they're working on. In fact, there's so many projects going on at any given point in time, it's hard to keep up with them. Ben Levy can hold me to that with some of the stuff that we've been working on, got put on hold, and we'll circle back to that. But it's a good sign, I think, because it means we're very active in that realm.
Very good. And one other comment, maybe for any of the residents out there, there was a question about medical students and teaching. And I know things have been a little bit different this year with COVID and distancing, but do any of you want to comment on when we have medical students rotating through, what are the expectations for teaching and kind of that mentorship role? Maybe Shannon. Can we hear from you, Shannon?
Yeah, sure. So that's a good question. We do have medical students that routinely rotate through the different departments. Unfortunately, due to COVID, the medical students aren't physically there with us right now, but before COVID, we did have a lot of sort of side-by-side screen teaching with the medical students, particularly at the VA, I think, which is actually pretty nice because the VA is a little bit slower site for us. So There's a lot of time to really teach the medical students. They can ask us questions. I think kind of, as a medical student, you don't get a ton of exposure to radiology. So I think just kind of showing them like what our day-to-day life looks like, kind of just pointing out some of the bigger picture things. And I think overall it's hopefully an enjoyable experience for the medical students, and it's kind of fun for us to show them what we've learned and answer questions about what our life is like. So
I'd like to chime in. I'd like to chime in for that question. I've been able to observe excellent teaching from residents to medical students, but also faculty takes a really serious part of teaching medical students as they rotate through the reading rooms. Dr. David Nassine, who's not here tonight, I think he's the head of medical student education, and he puts together an amazing didactic schedule for the month for medical students on top of medical students rotating through. So we take education very, very seriously, whether you're just a medical student going through, or a resident that we own you and care about you and want to make sure that you learn as much as you can while you're here.
Good. Rena, did we miss anything there?
Well, I guess like one thing is that we also get medical students when we're TYs. So, I mean, probably towards the beginning, we don't have that much to teach, but as you go on through your, intern year, you kind of obtain this like broad, I guess, bank of knowledge that comes from rotating through different services. So that's kind of fun too, because, it's a little bit more relatable to the medical student experience going through different rotations, especially if, you have a third year on with you, then you can kind of let them know what to expect and, so.
Very good. Thank you guys for that. I think before we break as faculty, I'm going to surprise them, but I'm going to do it anyway. I'd like to call out a few people here. Sherry with an S, Sherry with a C, and Morgan. I don't know if they are willing to show themselves, but these are folks that are the glue behind all of our, work in the front. They're working tirelessly behind the scenes. And our coordinators, Sherry, was instrumental in setting this meeting up, Sherry with a C, but Sherry with an S is doing so much that I can't even begin to describe, along with her sidekick, Morgan. And so we are really grateful for you guys too. If you are in our program, you will be smart to get to know these guys, because they are, they're here for you too, and they work so hard to make the program great as well. So thank you, Sherry. Thank you, Morgan. Thank you, Sherry with a C. Got lots of Sherry.
You're welcome.
Got lots of Sherrys. So with that, I'd also like to say thank you again for joining us tonight. This is, like I said, new to all of us, and I'm pretty excited at how this went. And it's not over. Hopefully our residents can stick around a little bit longer. We will jump off as faculty, so you can get down to the nitty-gritty. We're not going to hear. So thank you again. Feel free to ask us any questions. You'll have our email. We're open for questions afterwards moving forward. And good luck on match.